Good morning, everyone, and a very warm welcome to CRAN's My Colorectal Cancer Coach Summit 2026. My name is Christopher Mamalidi. I am the National Patient Programs Manager here at CRAN, the Colorectal Cancer Resource and Action Network, and it's an absolute honor for me to be facilitating this summit with you this year. We're sending everyone our warmest during this Colorectal Cancer Awareness Month as well. For this event, I am joined by our amazing My Colorectal Cancer coaches, whom we will be introducing shortly. I'm joined as well by our team members, the incredible Cassandra McCauley, our Chief Research Officer, our CRAN team, of course, and the one and only, the dedicated, passionate, and inspirational founder, our President and CEO, Filomena Servideo Italiano, who I would love to turn it over to in order to welcome our community today.
Thanks very much, Christopher. Well, good morning, my friends, and welcome. Welcome to day one of CRAN's My Colorectal Cancer Summit, a very unique 5-day evidence-based event providing our colorectal cancer patient and caregiver community with expert insights on the management of their disease to help navigate their journey with confidence and competence. I'd like to firstly acknowledge our cancer coaches, upon whom this summit was established. For 5 years, CRAN has convened experts across the continuum of colorectal cancer care to deliver evidence-based information as part of the annual training and certification requirements for CRAN's My Colorectal Cancer Coach program, a program that provides evidence-based information and compassionate support through one-on-one coaching for our colorectal cancer patients and caregivers who contact us across the country after receiving a diagnosis of colorectal cancer. Getting screened for colorectal cancer or being newly diagnosed can be an overwhelming and life-altering event, but having an experienced guide and mentor to help answer questions along the way is absolutely invaluable. Our dedicated and highly committed colorectal cancer coaches receive mandatory annual training and certification across the continuum of colorectal cancer care to help guide patients and caregivers through their screening, their treatments, or survivorship journey. They are entrusted to help patients cope more effectively with the everyday challenges that are associated with the cancer journey, and they also assist patients in making informed decisions together with their treating clinicians regarding their care. I warmly welcome and I thank our 14 cancer coaches today who are assuming 18 different portfolios as they move forward to assist our patients and caregivers across the country. And in 2025, we decided to expand this annual training and certification program by opening the virtual event to you, our colorectal cancer patient and caregiver community, as silent viewers, so that you too could benefit from the depth and breadth of expert content being provided and delivered by 27 expert speakers. Our inaugural virtual My Colorectal Cancer Summit was held in May 2025, and it was a great success. So much so, we are now once again opening it up to the patient community because patient education is a critical step towards patient empowerment. Because we know that individuals who are well informed about their disease, its management, and about healthcare system navigation are better equipped to actively participate in shared decision-making and advocate for their own priorities and needs quite effectively. So a very warm welcome to you, my friends, our colorectal cancer community, as we truly hope this virtual access to reputable, expert-led, evidence-based information will prove to be of great assistance to you as you move forward in your journey, regardless of where you are in the trajectory of your disease. It is my sincere hope that regardless of the content you access, it will provide you with the comfort, competence, and confidence you require to move forward in this life-altering journey. Today's roster of speakers are captivating and highly engaging. From understanding the basics of colorectal cancer to the medical management of early stage disease, we have secured for you the most highly qualified professionals to speak to today's scheduled topics. So sit back, my friends, and enjoy. Thank you for joining us. We feel quite privileged to be hosting you. Thank you, and back to you, Chris.
Thank you so much, Philomena. And to all those joining, just a little special message, especially those who are living with or have been impacted by colorectal cancer. We are terribly sorry you are on this journey, but we will share. We're so glad that you're here with us today. Our hope ultimately is to provide you with the patient-focused, evidence-based support and information needed to navigate your personal journey with confidence. Please do always feel free to reach out to our dedicated team anytime we can be of assistance. Okay, so very quickly, we will go through a bit of housekeeping. So this morning, I'll just go through quick housekeeping notes with you. I will share that the summit is being recorded. Viewers cannot be seen or heard, so there's no need for you to worry about your mic or your camera. All registrants will receive exclusive early access to the recordings before they become publicly available. To view today's agenda, click on the Sessions tab, and you'll see that highlighting there in the top right-hand corner of your browser. Across the top navigation bar, you can also learn about our expert speakers in a little bit more detail by visiting our sponsor pages and also see bookmarked sessions within their personal itinerary. Some sessions will have resources available for download, and you can click on the individual session within the Sessions tab to view its reference material in advance. Or once you're in the meeting, you can click the resource, and you'll see it highlighting there as well, icon, to access the downloadable resources. Please leave the lobby open in your browser during the summit. When each session ends, you'll be prompted to rate the session. And this is really important, and if you can, please make sure you take time to rate. And then you'll need to return to the lobby to join the next session that's of interest to you. Should you experience any technical difficulties at all, our team is here to support you. Please reach out to our communications manager, Alyssa Salmon, should you require any assistance at all. Okay, I wanted to give just a little bit about CRAN. I know some people joining today may not know much about our organization. It's important that you know the motivations ultimately to the people in the organization behind CRAN. So I wanted to take a moment to introduce CRAN for the benefit of some of our newer members, and of course for those watching that may not be entirely familiar. The Colorectal Cancer Resource and Action Network, or simply known as CRAN, originated as a grassroots colorectal cancer information and support group back in August 2006. This was 1 month after the passing of Philomena's father, who was afflicted with widespread metastatic disease. Today, CRAN has proudly become a national, not-for-profit, patient-focused organization. We're governed by an experienced board of directors, and we're counseled by an expert medical and scientific advisory board, of which many members are generously participate in these events. At CRAN, we have 2 patient advisory councils, one of which is dedicated to the under 50 patient population, to which I belong myself, whose past experiences with the disease help to inform our program development to ensure our services are relevant and meaningful. In terms of mandate, we champion the health and well-being of Canadians touched by colorectal cancer and others at risk of developing the disease. And we do this by providing 3 major pillars: support, education, and advocacy to patients and their caregivers, which is a very important distinction, to help improve a patient's quality of life as well as their longevity. CRAN has also expanded its patient-focused mandate to serve multiple tumor type patients through our HTA patient evidence submissions, educational events, advocacy initiatives, and some of our patient programming to ultimately reduce the burden of cancer in Canada. This is our ultimate mission. Up next, this is a good opportunity to introduce our coaches. So ultimately, there is no program without our coaches. Our colorectal cancer coaches stand ready to guide Canadians as they navigate the space with confidence, courage, knowledge, and ease. I do not have enough time or adjectives to tell you how wonderful these people are. I've been blessed to work with them for over a year now, and they are absolutely incredible. They're dedicated, they're compassionate, altruistic, inspirational, knowledgeable, and extremely kind and empathetic. We at CRAN are incredibly grateful and humbled by their contribution, and I mean this from the bottom of my heart. So let's take a moment to introduce them because it's important that we go through and everybody can kind of visualize who the coaches are. So up first, I'm just going to go from left to right. Um, Filomena Servideo Italiano, of course, who is my clinical trials, my biomarkers, and my CGP coach. I know we introduced Filomena already, but Phil, if you just want to give a quick wave. And we also have Ms. Jessica Dassler, who is my advocacy and my lung mets coach. We have Cassandra McCauley, who is my BRAF B600E coach. We have myself. My name is Christopher Mamelidi. I am my young adult CRC coach. I am a 3-time survivor myself, so it's an honor to be in that position. We have Miss Sonia Graywall, who is my genetics coach. We have Miss Cheryl Silverstein, who is my Lars ostomy coach, as well as my survivorship coach. Who've just joined Mr. Don Wood, who is my caregiver coach. We have Mr. Steve Slack, who is my liver mets coach. We have Marie Terasi, who is my early stage CRC coach. Marcelina Dolores, who is my immunotherapy coach. Michelle Green, who is my psychosocial coach. Frank Pittman, who is my screening and my French CRC coach. Susan Wakut, who is my peritoneal coach. And of course, Philip Hussel, who is my chemo side effects coach. So our coaches will be sharing more information about themselves as we close the event, throughout the event ultimately, and I encourage you to tune in to learn more about their lived experience. Lastly, thank you, coaches. To our audience, if you've been impacted by colorectal cancer, whether you're undergoing screening, you're a patient yourself, a caregiver, or you're in survivorship, please, please, please reach out if you're in need of any support or information. That's why we're here. It's what we want to do. We want to be here to support. These amazing humans are ready to help and want you to feel empowered and connected as you navigate your next steps. So again, please never hesitate to reach out to us and our team. Okay, so very quickly, I will try and run through the agenda just to give you a quick idea. Today's agenda will be beginning with an understanding of the basics of colorectal cancer in our CRC 101, and then we will convert, and this is, the first 2 sessions are with Dr. Wang, Dr. Christopher Wang, and after we go through the basics 101, we will also review, ultimately, how do we screen for it? The next, we'll have a session, on using the prevention lens with preventative cancer, vaccine for Lynch syndrome, a clinical trial. And this is joined by Dr. Eduardo Villar Sanchez, which I know many, many are tuning in to watch this incredible session. Up next, after that, we have our lunch break. We hope you get a minute to eat and relax, of course. And then we will come back to discuss the radiotherapeutic management of primary colorectal cancer with Dr. Christopher Dennis. And then we also move on as well to a very, again, high interest session with genetics. I know this is something that patients are often talking about, so it's great to have that perspective from our own Miss Sonia Graywall. And ultimately, this is important to make sure that we get a better understanding and have a conversation around things like hereditary syndromes. And lastly, we finish the day with the medical treatment of early stage disease presented by Dr. Salawu. So we hope everybody can get comfortable, have your pens, your papers, your tablets, laptops, whatever it is that you utilize. And following each expert presentation, our cancer coaches will enter a 15-minute closed interactive discussion with our experts so that they can ensure adequate knowledge, translation, as well as content acumen. So we're going to ask a lot of questions and be able to have that dialogue. During these gaps in the schedule, we encourage our viewers at home to take an additional 15-minute break to grab a snack and just be able to kind of regenerate a little bit. Okay, so with All that intro done now, we move on to our experts. Up first, in our first session that we have today, is screening of colorectal. Oh, I'm sorry. CRC 101, understanding the basics. Sorry, I had a technical issue there. To introduce, we have Dr. Christopher Wang, who's a gastroenterologist at St. Joseph's Healthcare Center in Toronto. He completed his MD training at U of T and his internal medicine and GI residence in Edmonton, Alberta. Upon returning to Toronto, he completed a fellowship in clinical nutrition at Toronto General Hospital, and he currently runs a nutrition program at St. Joseph's. He manages inpatient TPN service as well as outpatient multidisciplinary malnutrition clinic. He also has an interest in medical education and is currently serving as the education lead for community GI at St. Joe's. Without further ado, I would love to pass it over to Dr. Christopher Wang.
Thank you so much. Thank you, Chris, for that introduction. Can everyone hear me okay? Perfect, great. I'm going to share my slide in just a sec here. All right. Hopefully everyone can see that okay. I'm going to move myself to the middle here. All right, great. Thank you again for this opportunity to speak to all of you. It's really inspiring that so many people have come together to advocate for this very important cause. And I'm very honored to have been invited to give not one, but two talks. So you'll be sick and tired of me probably by the end of the morning. But we'll go through two topics. The first focuses a little bit more on the science of colorectal cancer. And the second, we'll talk a little bit more about screening. If at any point there are any questions, I think for the coaches, there's a time to address it afterwards, but feel free to jot them down. So this is my outline for this first session. We're going to talk a little bit about the anatomy of the GI tract. We're going to talk about how colon cancer develops from the polyp stages to adenocarcinoma. We're going to delve deeply a little bit into polyps and different kinds and classifications. Moving on, we'll do staging and grading of colon cancers. And then I'm going to end off as a bridge to the next session about some Canadian statistics that we have in terms of colon cancer. And I think this is a very apt time to be talking about this as it's been in the news. And so I wanted to capture some of that urgency and momentum. So yes, that'll be our agenda for the morning. So to start off, the really basics, you all are probably familiar with the basic anatomy of the GI tract. In total, it is generally about 60 to 100 centimeters, depending on your size of your body. It's roughly divided into the different segments, the anal canal, the rectum, the sigmoid colon. You've got the descending, transverse, ascending colon, and cecum. This chart here outlines some of the expected diameters of the colon. There are common sites of issue when it comes to colonoscopy, and I'll talk about that a little bit more in our second session. But areas that we focus a lot on as gastroenterologists is the cecum and ascending colon, as well as the sigmoid colon, because these areas are narrowest and often difficult to assess fully. And so we spend a lot of time there looking for polyps. I wanted to briefly talk about the blood supply, not that it is a very important information, but there are some nuances that I feel are important in the topic of colorectal cancer. So the GI tract is a very well vascularized organ. It needs to be this way because it absorbs nutrients from the small intestine, and it absorbs water from the stool. And most of the blood from the intestines returns via the portal system. So it's this collection of veins that drain the blood from the intestines. It all filters through the liver and then makes it back to the heart to be reoxygenated and circulated throughout the rest of the body. That is true for almost the whole intestine, except for the very, very last part in the rectum. And this is important because metastases for colon cancer typically follow the first site of drainage, which is why in colon cancer, oftentimes it moves to the liver. However, in rectal cancer, we often see other sites of metastases, such as lung and whatnot. And that's because the blood flow coming from the rectum actually bypasses the liver and goes directly to the heart, which can then circulate to other organs within the chest and sometimes in the brain. And that's the only reason why the blood flow matters in this particular context. If we take a cross-section of the GI tract, the whole GI tract from the mouth all the way to the bum is composed of four main layers, the mucosa, the submucosa, the muscularis propria, and the serosa. And the amount or the proportion of these layers varies depending on where you are in the GI tract. Within the colon itself, we're mostly focusing on the mucosal layers because this is where polyps typically tend to grow. Now, polyps start off as abnormal collection of cells in the mucosal layer, and these cells receive some genetic change, which causes them to replicate uncontrollably, and they start to grow. And as they grow, they develop more and more genetic mutations, leading to a process called dysplasia. And that's when we would classify it as a polyp, is when there's these changes that we classify as dysplasia. Now, they don't become cancer officially until a few things happen. Number one is that the abnormal cells breach the mucosa and enter this submucosal layer. And that is important because there are blood vessels in the submucosal layer. And so when a polyp breaches the submucosa, it now has a risk of spreading, and therefore we call it an adenocarcinoma. If the cancer continues to grow, breaching the other layers, we now refer to it as an invasive cancer because it's burrowing into the muscle layers, maybe into other organs as well. And that's when we would classify that as an invasive cancer. And I'll talk more about staging in a little bit. Once again, we're still learning a lot about the genetics of colon cancer, and so I'm not, and there are many experts following me that will be speaking more in depth about this topic. But just to give you a brief overview, we think that there are certain mutations that then put this mucosal layer at risk. Certain genes have been associated with this, such as the APC gene. And then moving on towards the more advanced cancers, they acquire more and more mutations to very important oncogenes such as the p53 gene, the KRS gene, and these, as they become mutated, will lead to growth of the cancer and formation of blood vessels into the cancer itself. Again, more research definitely needed in this area. Just to give you a sense of the timeline of this, because many patients often ask, how long does it take for a polyp to form or for a polyp to become cancer? And it's actually a good amount of time. We think that after the initial mutations, we're talking a range of somewhere between 10 and 20 years in order for these, what we call a benign polyp, to perhaps develop enough mutations to then become an adenoma. Now, Now, this varies, of course, depending on the gene mutations and the gene susceptibility. There are patients who are at higher genetic risk, whose polyps develop far more quickly. But on average, we are talking somewhere around the range of 10 to 15 years. And this is why our colon cancer screening guidelines set the intervals at the pace that they do, because scientifically we think that on average, polyps are actually fairly slow-growing pathologies. And for this polyp to then become a cancer and for then the cancer to start causing problems, we are talking another somewhere 10 to 20 years. And so I get the question a lot of times, why are we stopping screening at 75? And this is potentially one of the reasons why. We think that it takes a very long time for polyps to grow into cancers and then to cause problems. And so that's typically why most screening guidelines end at the age of 75, but I'll talk more about my personal opinions of that later on. So very, very briefly, this is stuff that gastroenterologists really obsess about, but I only mention it just because you may come across these terminologies. Perhaps patients may read a scope report and see these codes on there. And so I thought I would just mention briefly how we classify polyps. And so we follow this Paris classification based on what we see. It's a visual classification scale. It mentions nothing about histology. We don't know what kind of polyp it is. We're merely describing what it looks like when we do our colonoscopies. We have first our pedunculated lesions, which have a very clear stalk leading to the polyp. And in contrast, we have the sessile polyps, which have a broad base. And so we label those as 1P or 1S. And if they fall somewhere in between, we call it a 1SP. For larger lesions, they either come as flat elevated lesions or flat indented lesions. And we have a different classification scale for that as well. And they take on the codes of 2A, 2C, or sometimes 3 if it's a very indented lesion. These are typically rarer polyps or larger lesions, and so you may not necessarily see those classifications, but you will very commonly see the first set of protruded polyps, 1P, 1S, and 1SP. And so if you ever see those on your colonoscopy report, it's merely a way of describing the polyp visually based on what it looks like. What we actually care about is what kind of polyp it is histologically, meaning what kind of cells or configuration this polyp takes up. And the reason why this is important is because each type of polyp carries a different risk in terms of developing into malignancy. And so the most common type by far is our tubular adenomas, or adenomas for short. In general, they occur in about 45% of cases, and they do carry some malignant potential. We think about 2% per year. And this is the most common kind of polyp. This is why we do colonoscopies, is to find tubular adenomas and remove them before they can become cancerous. Within the adenomas, there are slight changes to the configuration of cells that increase their malignant risk. And so if they develop kind of thin projections, almost like the villi, so the projections of the small intestine, we call them tubulovillous adenomas, or if they're completely villous, we just call it a villous adenoma. These are slightly rarer, but they do have a higher malignant potential. So while we may only see them in 6% or 1% of cases, their malignancy rate can be upwards of 20 to 40%. And so these polyps, when we detect them, it does change the screening interval. which I'll talk about in a little bit. Um, Moving along the circle as well, at the lower quadrant, you see the adenocarcinomas, and by default, they are already malignant lesions, and so that's why the M number is 100%. They are by definition malignant, but they are fortunately quite rare. And obviously, when we talk about screening programs, this is what we're trying to avoid: is doing a colonoscopy and finding, unfortunately, a malignancy already there. This big green wedge here are hyperplastic polyps. These are also very, very common. And if you see these on the report, you can be reassured. There's zero malignant potential. And I tell my patients that even if we were to leave them in forever, they would never become a cancer. And so this is the most benign kind of polyps. And they occur actually quite commonly, usually at the distal end of the colon, so closer towards the sigmoid colon or rectum. Very common to find these hyperplastic polyps. As GI doctors, we remove them anyway because we don't know sometimes whether they are adenomas or not. And so if we see them, we're going to remove them anyway. But if they come back on the colonoscopy report as hyperplastic polyps, we are reassured. And we can, it doesn't necessarily change the screening interval for our patients. And so this kind of information is obtained by the pathologists where we send our polyps. And it's really important for us to maintain a good relationship with our pathology colleagues because we get this kind of information quite readily. And it's nice to be able to talk through some of the more complex cases. Now, in terms of what we do after a colonoscopy, depending on what we find, it may or may not change the screening interval. And so we consider a high-quality colonoscopy, one that is complete, one that goes all the way to the cecum. Sometimes the gastroenterologist may also look into the small intestine, an area called the terminal ileum. And so that is our way of documenting how far we were able to go with the colonoscopy, but we expect a high quality colonoscopy to go at least to the cecum. We like for the bowel prep to be good enough to detect small polyps, and this means anything under 5 millimeters. You want your colonoscopist to be well trained and to have done enough procedures to prove that they are able to detect polyps on a colonoscopy. And so we have a metric called the adenoma detection rate, or the ADR. And it's something that as endoscopists we track and we monitor because you want to be doing your colonoscopies at a center that has experts in performing these procedures. And you want to ensure that when we do see a polyp, we can get it out completely, and we call that a complete polyp resection. There are times, whether due to the size of the polyp or due to the complexity of the location, there are times where an endoscopist may not be able to fully remove the polyp in one go, in which case this screening intervals do not apply in those situations. The endoscopist would usually try to bring the patient back much sooner to complete the polyp removal. Assuming that you've met the criteria for having a full, high-quality, complete colonoscopy, your next colonoscopy range depends on a couple of factors. If it was a completely normal colonoscopy, or if we find some hyperplastic polyps, that's the HP, which are less than a centimeter, then the screening interval is 10 years for an average risk individual. This chart does not apply to individuals with a family history or a high-risk individual. We'll talk more about those a little bit later. If we find anywhere from 1 to 2 adenomas, we would typically recommend that the patient returns back in around 7 to 10 years. These sessile serrated polyps are another kind of polyp that we can find. And if we see some of those that are fairly small, again, the guideline does not change in terms of interval. Where we might shrink the interval is where we find a few adenomas, so 3 to 4 adenomas under a centimeter. That's when we would say come back in 5 years, for example. If we find, again, quite a few sessile serrated polyps under a centimeter, or if we find a hyperplastic polyp, even though it's a benign lesion, if it's quite large, above a centimeter, that is also another reason to come back in at the 5-year mark. When we shrink that even further, we are now entering the domain of higher risk lesions. And so anywhere from 5 to 10 polyps on any one colonoscopy will buy you a repeat colonoscopy at 3 years. If we find an adenoma with any of those villus architectures, so either a tubule villus adenoma or villus histology, that is also a reason to bring the patient back within 3 years. When we see dysplasia, as I said, by default, all polyps have a little bit of dysplasia, but when the pathologist comments on high-grade dysplasia, that is a reason, again, to bring the patient back much sooner. And then any other kind of serrated adenomas with dysplasia are also considered high-risk lesions, and for that, a patient would come back sooner for their colonoscopy. If we do a screen colonoscopy and we see more than 10 polyps and they all come back as adenomas, that patient is coming back in 1 year, because the thought is that when you hit that number, just from a timing perspective, it's often difficult to remove more than 10 polyps in one colonoscopy. And the assumption is that there may be other smaller polyps that may have been missed. And that's why if the pure number of polyps exceeds 10, we typically do recommend a repeat screening colonoscopy within the year as a way of as ensuring completion and ensuring that we've caught all of the polyps detected on that first round. I'll talk very, very briefly about staging. I believe, again, you have other experts following me who will delve more deeply into the cancer treatments. But this is typically what I would do if I see a concerning lesion. And so if we do a colonoscopy and I see a lesion that is concerning, either I think it's an adenocarcinoma, like a cancer, or it's a polyp that perhaps I might not be able to remove due to technical difficulties. There are a couple things that I do. Number one, if I have a surgical colleague scoping nearby, I might call them into the room to just have them assess that as well. At St. Joe's, we're very lucky to work quite closely with our surgeons, and we often have them around to assist with more complex cases. But if they're not available, then I place a tattoo. And the tattoo is important because it helps us to localize the lesion of concern, and it prepares people potentially for surgery. So what the tattoo is, it's a dye, it's a black dye that we inject into the submucosal layer, and it stays there and it's visible on the other side. So if a surgeon does eventually need to take the patient for surgery, when they are doing their laparoscopy, they can actually see the black dot on the other side, and that informs them of where the lesion of concern is. And we can do this via our cameras. We place a small needle through the colonoscope, and we inject a couple of spots just to make sure that they're visible from all angles. And after we place that dot, we will complete the rest of the colonoscopy, removing all the other polyps to make sure that apart from that lesion, it is still considered a complete colonoscopy. The reason why that's important is because if the patient does eventually go on to surgery, oftentimes a large segment of bowel will be removed. Polyps that are very close to that lesion will be taken out, but the polyps in the remaining area of the colon are not addressed in surgery. And so it's really important that we ensure that everything further away, more distal to the lesion, is removed, and to ensure that the surgery will take care of everything else. If we're quite convinced that this is likely turning into a situation where we're dealing with a new diagnosis of colon cancer, we, along with the surgeons, will arrange for further imaging. We will take a CT scan of the chest, the abdomen, and the pelvis, looking for any areas of metastasis or spread. We may order a bone scan, or perhaps even a head CT to look for brain metastases in the cases of rectal cancer. Based on all of the findings, we assign a TNM stage, which I'm sure you're all familiar with, and that does end up dictating the type of treatments that are available. But one thing I find that often gets missed, especially by by gastroenterologists at our stage, and something that we can easily do is just inform the patient and their family to contact their first-degree relatives. This often when a diagnosis of colon cancer is first made, obviously there's a lot of information and it can be quite overwhelming. I try really hard to walk my patients through all of that. But one very important step that I try to get them to address is to contact their first degree relatives. And that means any siblings, any children, and their parents as well, if they are within the screening ages, but mostly it's siblings and children. They are now all considered at higher risk for colon cancer because there's a family history in a first degree relative. And so I tell them to inform their family. Sometimes it does involve calling people out of country and whatnot. But these patients, if they fall within screening guidelines, need to undergo a colonoscopy themselves. And that's why it's important that we always mention to the family to take care of that. Um, Again, very, very briefly, because other experts will be talking about this more in detail. The TNM staging classification allows us to assess the stage of colon cancer based on three factors: how far the tissue has spread, or T, if there are any nodes involved, or N, and whether there's any distant sites of metastases, or that's the M classification. And so based on those three criteria, we assign scores, and we combine them in various ways to call a colon cancer stage 1, 2, 3, or 4. And down at the bottom, I've outlined, again, I think this is actually old data, so the numbers might not be perfectly accurate anymore, but we talk about the survival rates at both 1, 3, and 5 years, depending on your stage. And so the stage 0 to 1s do typically quite well, and that tapers down depending on the stage of the colon cancer. And as I said, I'm not sure if these numbers are, I think they look a little bit old to me, but I just wanted to give you a sense that the survival, at least if we can catch them early enough, is quite good. Um, Again, very briefly, just to give people a rough idea of what to expect in terms of treatments based on your stage. There may be a couple of things that are offered, either upfront surgery, meaning that we remove the lesion first, and then figure out afterwards whether there were any other distant sites of involvement, like a lymph node or something, and based on that, they undergo chemotherapy. There's something called adjuvant chemotherapy, which happens before the surgery, and sometimes that might be recommended. And based on other more specific details about the colon cancer, sometimes radiation is offered, or anything to do with the liver, perhaps a resection of a liver metastasis, for example. But these are very, very unique cases that are handled by a big multidisciplinary team of oncologists and surgeons and radiologists. And so this is not something that as a GI doctor I would necessarily be involved in moving forward, but it is something that we think about when we are first assessing and making a diagnosis. Based on the stage or the TNM staging, they will assign any or some of these treatments. As a gastroenterologist, we typically come back later on to do their next screening colonoscopy. Occasionally, surgeons may do this themselves if they have any concerns about the operation that was done, but typically they will come back to us. And this is something that I take quite seriously because patients have obviously undergone quite a lot in terms of their cancer treatments. And I want to make sure that all of that effort was not put to vain. And so we need to do regular screening colonoscopies after a treatment and cure of a colon cancer. We do the first screening colonoscopy about 1 year after the surgery. And as I said, sometimes surgeons take care of this themselves. But after the 1 year mark, we do another one 3 years after that, and then moving forward every 5 years from then on. And this whole process will last the duration of their screening interval when they reach 75 years old. And we will perform a full colonoscopy. Now they might have less colon due to previous surgery, but we will still assess the remainder of the colon there. And again, I put it on again because I can't emphasize this enough. As gastroenterologists, we really need to think about these patients as being higher risk individuals and their family, all first-degree relatives, as being higher risk individuals. And so the same kind of screening protocol needs to be applied to first-degree relatives as well. So for the last maybe 10 minutes or so, I think I'm on time. I just wanted to briefly talk about some of the data that we've been seeing around in the news. And I think it's so apt that we're talking about this now because very recently, some of you may have seen colon cancer come up in American headlines. Based on a recent study that was done, colon cancer is now the leading cause of cancer deaths in patients under 50 years old. And this is for the very first time that we are seeing this, but it is highlighting a slightly concerning trend for gastroenterologists like myself. All of the news agencies have captured this, and this is all right around the turn of the new year, which is when the study came out. It's from this article published in JAMA in January 2026, and I've left the link to that there. But based on the most recent data, colorectal cancers are now the leading cause of death for patients between the ages of 20 to 49, and that's based on 2023 data. It has now surpassed breast cancer and other cancers, which are fortunately declining, things like lung cancer due to obviously public health interventions. But colon cancer, unfortunately, seems to be moving in the opposite direction. And this is better illustrated by this chart here. This is the change in cancer deaths between 2014 and 2023. It's a comparison of various types of cancers. And so fortunately, all things considered, if we zoom out, look at the big picture, deaths from all cancers taken all together are decreasing, which is great. It's good news. It means that we are making progress in terms of the treatment of cancer and detection of cancer. But when you break it down into the different types of cancer, there's only one exception to the rule, and that's colorectal cancer. It has actually increased over the past 10 years. Why exactly that's the case, we're not too sure. Obviously, a lot of research is actively being done in this area, but this really highlights the importance of what we do and of what family doctors do to advocate for patients going for screening. And it highlights the important work all of you are doing in terms of advocating for colon cancer awareness and screening, because this trend really needs to turn around. Outlined here are some reasons why other cancers have decreased, such as reduction in smoking, leading to a drastic decrease in lung cancer. Improvements in mammography and other screening modalities have led to a decrease in breast cancer. And as I said, the only uptick in the different types of cancers is colorectal. And so that's just something that I personally feel very moved by, and I think a lot of my colleagues feel the same. And so with that, I will leave it at that for the first session. We'll go into more details about colon cancer screening in the next section. But if there are any questions, I can address them here, or we can move backstage.
Wonderful, wonderful. Thank you so much, Dr. Wang. That was absolutely an incredible 101 or intro to colorectal cancer. So thank you so much to the viewers, our silent viewers. Just a reminder to head to the lobby to join the next session. And coaches, please do enter the backstage for our follow-up 15-minute discussion with Dr. Wang. And then we will return audience, I believe, at 10:45 for our next section with Dr. Wang to follow up with the screening for colorectal cancer. See you soon.